anybody have any questions or? Yes, please.
Well, I don't have use of my arm
Mm-hmm.
anymore because I broke my shoulder like
Mm-hmm.
a little over 4 years ago.
Yeah.
And when the doctor did surgery,
Mm-hmm.
I went to physical therapy
Mm-hmm.
and she kept trying to get me to be able to raise my arm
Mm-hmm.
after, a month or so.
Mm-hmm.
And I could never do it. So finally they discovered that when I had my surgery,
Mm-hmm.
that the muscle didn't get connected to the bone.
Sure.
And
So that's what I was talking kind of about before, is that there might not be anything necessarily wrong with the muscles on the outside of your shoulder, but if you lose the attachments of the rotator cuff.
right, I can't
Mhm.
raise my arm any
Yep.
higher than that.
Mm-hmm. Yeah, so the technical term for that, if you were to Google it, is referred to as pseudoparalysis. The reason it's pseudo is that it's not an actual paralytic condition. What it is the fact that the mechanical hinge is not intact with the tendon.
And not only
Yeah.
that, it hurts a lot.
It's usually uncomfortable, yes. Yes.
At times it's very painful.
Yeah. Yeah. So that was one of the indications that sort of these new style replacements were brought for, was to address that. Because, and actually within the last decade, there wasn't a good answer for that, which is unfortunate. But now there is to some degree, although it's not a small thing, right? It's not like a small undertaking. So it's a little bit of a personal decision as to do you go forth with that or to look into it.
Whether I would want to have surgery.
Yeah, and don't get me wrong, I don't want to try to recommend anything to you after, without having, getting all the clues, right? I mean, you don't want anybody to sort of shoot from the hip, right? So, I mean, with any before surgical intervention, particularly a major one, which would be, a replacement, you would want all the details. You'd want to know what was done, so you'd want your operative report from your prior surgery, prior imaging, new imaging, right? And then obviously a thoughtful physical exam to understand, what is there and what's going on. But those are things if within that story, the way to address that typically, which this isn't an unusual story, to be totally honest with you, is unfortunately, it's not that unusual. Yeah.
The muscle doesn't connect with the bone?
Yeah, so I'd have to look into it a little bit, you know what I mean? But it's not unusual with some of those injuries to have a lack of function or a loss or some problems with the rotator cuff. And so, after that, it sort of has to be addressed with this different style of replacement. I mean, it is theoretically possible to attempt to reattach the tendons. Oh, this is a good point. Okay. So you can attempt to, but what happens is if you tear the tendon off, basically it's attached to a muscle. And if you don't it's not using the muscle, because even if you fire the muscle with your nerve, it's not attached to anything. So what happens is the muscle shrinks, or the technical word we use is atrophy. Okay? And so this has been well studied. And so even if you reconnect it, the atrophy doesn't go away. And so once it atrophies to a certain degree, which is a classification by a French surgeon named Cagle, who once it basically atrophies to a certain percentage, it doesn't really have a high functionality. And that surgical attempted repair is mostly all risk with low benefit. And so you wouldn't want to attempt it. In the acute phase, you theoretically could, depending on the details. But it would depend a little bit on the details and the timing. Yeah.
So in other words, I need a doctor's appointment.
You do, yeah. If you need somebody to look at it, and that's it's something that sounds like it can be addressed though. I mean, there's problems that you can't address, and there's problems that you can. That sounds like it's in the realm of can. So yes.
How long does it take that muscle to atrophy?
Excellent question. No one knows.
Okay.
Excellent question.
So
Excellent.
for 10 years, you probably.
There is nothing to say.
You may not be able to get it back.
So we get really anxious about this, right? Because if you tear it, I would say there's no data suggesting anything more rapidly than 12 weeks can be literally said. But there's after the 12 weeks, there's no magic day. I would just say most people say that as like a comfortable gestalt, right? Because unfortunately, it's exceedingly difficult. Because what you would have to do to study this is you would have to find people with tore tendon not repair it intentionally, and then sequentially get MRIs on them.
Yeah, nobody's gonna volunteer.
No one's going to volunteer. No one's going to volunteer. It's not even ethical. And so that's the trouble, is that data is almost unobtainable.
But the percentage of people who have a problem and live with it for years is probably pretty high.
All the time.
So they
All the time.
all have to have atrophied muscles.
Well, it depends. Some do, some don't. It depends on if it's totally torn, partially torn. There's a whole spectrum, to be honest with you. And just because you have a problem doesn't mean your muscle atrophies. You can have a problem or inflammation in the tendon, and it can hurt like heck and limit your whole life, and it doesn't mean that you're any less strong. Yeah. But it's a very controversial topic, and at some point, someone's going to figure out a way. It would be an interesting histologic examination, but it would be quite an undertaking. So you need a huge number of people to prove it. So.
If people wanted to see, does their primary physician have to refer them?
So I think that depends a touch on your insurance. I mean, I'm happy to see anyone, and if you call my office, they can usually sort that out for you. They're pretty savvy about that. But I think the most complex thing in healthcare today currently is the healthcare insurance system, and so I think that's actually more complex than the surgery, and so yeah.
More painful.
Yes, it is. Yeah, for both of us. Yes.
From MRI or X-ray,
Uh-huh.
are you able to tell whether physical therapy or steroid injection is going to help, and therefore it's
So
not
it-
go straight into surgery?
From an appropriate diagnosis, you can tell. So it would depend on, does the diagnosis need an X-ray? Does the diagnosis need an MRI? I mean, yes. I mean, you certainly, with an appropriate diagnosis, you certainly can. But you can't see tendons on an X-ray. So if you have a tendon problem, the only thing you can see, so X-ray beams basically are absorbed by things that are dense. What's dense in your bone is calcium. There's no calcium in your tendon. And so the X-ray beams pass through your tendon and muscle. So that's why you can see your skeleton when you take an X-ray. And so unfortunately, you can't see them. So if you have a tendon problem, you tend to need either an MRI or some type of, sometimes you can use an ultrasound. There's not just one test you can use, but if it's a soft tissue problem, you would need a soft tissue imaging study if necessary, not always, but if necessary. And if it's a bony problem, an arthritic problem, that's actually better assessed with an X-ray, which is a common misunderstanding. X-ray is the best test for arthritis.
Yeah, because when I had my arthroscopic surgery 5 years ago, you started with rehab, physical therapy didn't help.
Yeah.
We went into injections, didn't help,
Mhm.
and then eventually arthroscopic surgery. What
Yeah.
I was thinking is, why not go straight into arthroscopic surgery instead of going through
It's a good question.
and then injection which don't help at all?
Good question. It's under the presumption that everything goes well. All right, so that's the presumption obviously we want to have, but it's not the presumption any thoughtful surgeon does, right? Because anything can have a problem, right? And so we would like to limit the risk to you in all ways possible. And by doing that is trying non-invasive means first. And so, because the risk of therapy is pretty low, the risk of surgery there are risks. Arthroscopic surgery is relatively lower in the risk profile than other surgeries, like a shoulder replacement or a fracture surgery or something like that. But it is much higher risk than therapy. So it's really doing the safest thing for you. It's not attempting to just, slow your life down for 5 months while, you slowly get to it. It sounds like whoever took care of you was thoughtful in that regard. So, yep.
In the case of like a suspected rotator cuff injury, tear, whatever it may be, is it better to baby that arm or to try and do physical therapy at home until you can get into the
Good question. So, neither. Yes, the best thing to do is to actually keep your motion, right? So it doesn't matter. So the odds of you becoming less strong rapidly are really, really low, right? But what you do is you don't move the shoulder. If you don't move the shoulder, what happens is the shoulder gets stiff. Stiff shoulders hurt, right? And other names for stiff shoulder are frozen shoulder, adhesive capsulitis, things like that, right? And you can get a frozen shoulder from a broken thumb. The reason is because you don't use your shoulder because your thumb hurts, right? And so the number one thing to do if you think you hurt it is to keep stretching it, right? And the most important ways to stretch it are just all, sort of all the way up and basically out and a little bit back. And those motions are the ones that no matter what, you have to get back. Even if you'd have surgery, you got to do therapy to get them back. And it's just one of those things where stiff shoulders hurt. They will, no matter if it's injured or not. Right? I mean, if you just kept your shoulder in a sling for 12 weeks and if there's nothing wrong with it, it will hurt 12 weeks from now, right? Most likely. Yeah. Yes?
With no apparent problem with function during the day, but at night,
Ah.
depending on which side you lie on, that shoulder will hurt.
Yeah, so rotator cuffs pathognomically hurt at night. I don't know why. There's some theories on that, whether it's you lay down and there's this distribution of basically equalizing the blood pressure. There's all kinds of reasons. But people with shoulder pain actually, for some reason, feel better when they sleep in recliners. Again, there's theories, but there's no real way to prove it. But yeah, sometimes that means you have a rotator cuff tear. It's not like a 1-to-1. Just because it hurts at night doesn't mean you have to have it. You'd want to do it thoughtfully with how the symptoms progressed and what a physical exam looked like, and if necessary, what an imaging study would look like.
So at what point should you go see a doctor?
Yeah, that's good question. So I think if you have an acute injury and you feel like something has acutely changed, right? So I fell, I slipped on the ice, I grabbed the railing, and now I feel like I can't lift things with my shoulder, right? That's a good reason. Right, that looks like something is acutely injured. And if it turns out not to be, great, good. Or I think at the point where you're like, I've tried dealing with it and this is significantly impacting my life, and that's very subjective. I mean, I can't tell you what impacts your life or timing or things like that, so I wouldn't want to put a time frame or a bracket on that, so to speak, but I think at that point it is, right? Clearly, if you see, another physician, like a primary care physician or something, and they have a significant concern, I mean, they usually do an excellent job of looking at people and getting kind of a screening exam. Or if you just have a question, I mean, there's nothing wrong with coming in to have something looked at. I mean, the only problem with that is, the thing you lose could be, 2 hours of your morning. So, I mean.
Is there such a thing as waiting too long?
Well, I mean, with anything you could. Yes, I mean, any problem if left long enough can be not reasonably correctable. But that's a real spectrum. And so, it might change the way you address it, right? So, if at one point it could be a repair versus the next time it's a replacement because of the timing and the things that have gone on. Or, there's sometimes you can have enough wear and tear to where it affects the ability to even put a replacement in, but that's pretty rare. Yes and no. I mean, I certainly don't want it to be in like a scary way, right? Like you got to run in and see someone right away. But anything is possible, and yes, that does happen. Yep.
Now, when you go to the reverse replacement, does that greatly limit your lifting ability with that arm?
I would tell you this, so the average person who has that surgery done tends to be a bit older, right? And usually that's not a functional concern. If you still had strength needs of heavy lifting, we wouldn't do it.
Right.
Yeah.
Because it seemed like the number I remember that I heard, last time I heard one of these talks, was like you're limited to like 5 pounds or with that.
There's no data. There's no data on that, right? So it is a relatively newer technology in America, okay? And so it's been used in France for 30 years. The newer designs have been used in America since 2004. The longevity on it is good, right? But whenever you start a new technology like this, the age bracket they originally used it for was 70 or greater. And so you don't have the data on durability in younger people. And even if you started putting it in younger people, you got to wait 10 years till you have that data. So it's a real lag, before you really thoroughly understand that. So most people's gestalt is that procedure tends to be usually the last one you would do, right? There's not a lot of things you do after that. And oftentimes at that point you do limit it because you don't want, anything, having to go back and deal with a problem with that is usually more than that person can either tolerate medically or needs to tolerate. And so, yes, I know plenty of people who would limit it to 5 pounds, right? I'd probably say, somewhere in that. I mean, I think the things you can't do is you can't do impact activities, right? So, you can't do, weightlifting or jackhammering or punching or hammering. Yeah, there's no more street fighting, you know what I mean? I mean, all that stuff is out. And so, but yes, that historically people have put a 50-pound weight restriction on an anatomic or a standard replacement and a 5 to 8 pound restriction on a reverse. I don't know if I necessarily have the same gestalt. I think, I think people, for the most part, usually don't lift things much heavier than that in their daily life. It tends to be a work-related problem, right, or a hobby-related problem. And if if you can't give up the work or the hobby, then we have to make a different decision interventionally, and that's okay. I mean, you got to go to work, but it's just one of those informed discussions.
The only reason you're going to that is because you don't have the rotator.
It is.
Once that's gone, you got nothing to hold the joint together anyway.
It's true. It doesn't necessarily mean it doesn't mean it's unstable. There's still a capsule. So the capsule is the tissue that sort of holds it to the ball, right? It's just the capsule is not dynamic. It's more just like a static rubber band kind of restraint. So it's not like the ball's just kind of flopping around in there. It's that it doesn't have that strong hinge to function normally anymore.
Is the torn rotator cuff able to repair itself with
Never.
constant movement?
Not by any data available in this country or the world. Yeah. Yes. Anyone who has proven that would be every now and again, someone has thought that's happened, but there's been you need actual MRI proof of a tear, retraction, reapproximation, and healing, and that to date has never been published.
That kind of gets implied sometimes, though, that if you do some exercise and physical therapy, you can heal up a rotator cuff. That's just...
Well, a partial tear or inflammation or tendonitis, the word heal is being used loosely, right? So the word heal is basically you working out the inflammation and the stiffness and regaining your strength and coordination. In some ways that is healing, but it's not healing in the sense of like the fibers gluing themselves back down.
Yeah, the tear is still there.
I would view it like a braided rope, right? Like if you pull on it long enough, the strands start breaking. By like cleaning the rope, the strands don't go back down. You know what I mean? But you can't get better from it, and just because you have a partial tear does not mean anything. I mean, it does not mean you have to have surgery. It doesn't mean anything bad. I mean, 50% of people over 60 with no pain have one.
I know what,
Yeah.
I saw her MRIs when they did that, and it was I think it was about 75% torn. It's pretty far torn.
Yeah.
What do you typically see in there? Is that typical?
So MRIs can lie to you. They can. And so you have to be thoughtful about your exam and your symptoms and things like that. The common number used is 50%. Right? And so once you pass about the 50% mark of the tear, there's a width, there's measurements there's all this stuff you can look at in real life. Then you would consider repairing that because it's kind of getting down to where it's, either about to tear or it's functionally limited. That is a very controversial indication, meaning that is not like a hard and fast rule. In a person who's completely painless, I don't think you'd repair that. I think if you have acute pain and functional weakness, that's something totally different. But you gotta get a good story with that. You gotta understand how it affects people and what they've tried.
When you start getting into that kind of tear, though, would you start looking at some kind of weight restriction on what you're lifting?
No,
So
once they heal, once your rotator cuff tear heals, you can do anything you want to do. I mean, it theoretically is healed, right?
Well, I mean, once it's just the inflammation's
Oh,
gone.
good question.
Yeah,
Again,
if you're living with it torn,
So,
should you be limiting your...
so by common sense,
Yeah.
maybe, right? But there's nothing to suggest that there would be an activity or a weight or an action that would cause it to complete. Because, if you look at people, these are part of normal progression of life. And so because of that, there's nothing to say that any of that was an injury.
Sure.
So, and if none of it was an injury, I can't tell you an injury is what's going to get you, And so I can't even tell you it's going to complete, right? Now there is data to suggest it might, right, over time, but there's a portion of people who don't. And so I think if you can't make anybody better than painless, right? And so if you don't have pain and you're fine, I would be pretty conservative with that, you know.
At what point do you decide whether it's open surgery or arthroscopic surgery?
Excellent, excellent. So the indications for an open rotator cuff repair, at least for me, would be a really, really tough second or third attempt. And the reason being sometimes there's so much scar tissue that it can be difficult to see, it can be difficult to use the fluid with the scope to actually even see in the joint. I think as far as my standpoint though, that's pretty unusual. I would probably be less than 2 or 3%. So almost all of them would be an attempt with a scope. There's nothing data-wise wrong with the open approach, right? This is another controversial topic. You know, the arthroscopic approach is nicer because there's smaller incisions. There's some thought that people might get better quicker, although again, that's very controversial.
Oh, that's actually nothing. Shorter scar.
Yeah, I mean, there's smaller scars, there's perks to each one. There's positives for the way you can address different problems, right? I would tell you that the trend in the country and in the world is to go more towards the minimally invasive surgical procedures, right? From my standpoint, the reason I would like it more is that the most important muscle in your shoulder is the one on the outside, which is the deltoid muscle. I mean, that's the big one. That's what does all the work. And you do the least damage to it with the arthroscopic approach, you know. But again, most or almost all of the open approaches, the deltoid heals very well. So it's not that it's necessarily dangerous. It's a little bit of preference and approach.